opening batsman is Dr. Durga, my colleague. She's going to talk on, do we need to investigate optic neuritis routinely? She's going to talk, yes.
A very good evening, everybody. Thank you, ma'am, for including me in this IC. So my talk for today is, I'm going to talk for, yes, we are going to investigate optic neuritis routinely. So optic neuritis is an inflammatory disorder of the optic nerve, and the most common cause can be multiple sclerosis as per the Western literature. But we all know that optic neuritis in Asian population has been reported to be atypical, unlike the Western population. And the understanding of optic neuritis is rapidly changing with the discovery of the new seromarkers, development of latest investigations, and the updated diagnostic criteria. So let me start with a simple, straightforward case. A 30-year-old male came to us with a sudden, painful drop in vision for the past 4 days. His vision in the right eye was 6x, left eye was counting fingers close to face, pupils had RAPD in the left eye, color vision was impaired in the left eye. And this is a fundus picture, this picture that you're seeing. Right eye had disc edema, left eye was normal looking, maybe a crowded disc. Fundus was normal otherwise. The right eye fields was relatively normal. Few peripheral defects, could be learning curve. The left eye was completely washed out. So the probable diagnosis is straightforward left eye optic neuritis. So do we investigate? Yes, I would prefer to investigate. Why? You see here, the patient is a male and he had a profound loss of vision in the left eye. There is a disc edema. So I would put this as an atypical category. It was an acute optic neuritis, but atypical. An MRI was done which showed optic nerve enhancement with a perineural enhancement too, and signal in the nerve was seen. And we did all the blood workup, NMO, MOG, granulomatous workup, autoimmune workup, and he turned out to be MOG positive. It was a MOGAD disease. So let's see some of the epidemiology of optic neuritis pertaining to our population. So previously in 1980s, we had a study stating that MS constitutes 0.3 to 1.5% of prevalence. That is 1.33 per 100,000 population only. And the recent studies conducted by the demyelinating registry at Mangalore told, that was in 2014, they had told the prevalence of MS was 8.3 per 100,000. And for NMO, it was 2.6 per 100,000. A substantial number of cases from this part of the world. Even in 1980s and now, it has been most of the atypical presentation. And from the same center, that is the Mangalore Center, they had another presentation saying that NMOST represent 20% of all the demyelinating disorders in South India, and out of which 30% were aquaporin positive and 20% were MOG positive, and remaining almost 49% were seronegative, that is both negative for MOG and NMO. And this is one of our publication from our institution where we found that almost 20% were MOG positive and close to 10% were NMO positive, and more than half of the cohort, that is close to 56% were seronegative, and the prevalence of MS was noted to be only 5%. So let's see, what is it? First, the typical, and we have to differentiate whether it's a typical and atypical optic neuritis. Typical could be a CIS, that is clinically isolated syndrome, or MS presentation, presenting as a typical neuritis. And we see that if the patient is young, female, unilateral, associated painful vision drop, subacute onset of vision drop, and retrobulbar presentation comes under typical optic neuritis. But it's totally the extremes of age, the profound patient presenting with profound vision loss, painless attacks, and bilateral involvement with severe disc swelling goes under the atypical category. And there are numerous causes for atypical neuritis. So initially we considered that NMOSD was just a variant of MS, but now it's designated as a separate entity, and though they have some phenotypic overlap. So here's a chart which says what are the different clinical features of MS and MS optic neuritis, aquaporin and MOG optic neuritis. The age group is slightly older in aquaporin and MOG, and we see that there is almost equal, there is no sex predilection in the MOG category, and painful attacks are seen mostly in MS and MOG, whereas painless are seen in aquaporin. Bilateral involvement is more common in the atypical groups, that is aquaporin and MOG, and vision is usually severe in aquaporin and MOG, and recurrence is noted more commonly in aquaporin and MOG diseases. And we see that the recovery is poor in NMO spectrum disorders, especially the aquaporin positive, and steroid dependency is more common in MOGAD. Visual outcome is poor in NMO spectrum. And the other association, literature says that ADEM is strongly associated with MOGAD, and area postrema or transverse myelitis are usually associated with aquaporin diseases. In the MRI, we see that the MS optic neuritis is typically short optic nerve involvement, whereas aquaporin is usually a long segment involvement, and in MOG, they have the classical perineural enhancement. CAs of oligoclonal bands are seen in MS optic neuritis. They can be seen. So next entity is the autoimmune conditions where we need evaluation. The causes could be Sjogren's, Charcot's, SLE, or even antiphospholipid syndrome. And we see that optic nerve involvement could be immune mediated or due to vasculitis leading to ischemia of the nerve. So the main thing is, like, they can be manifestation of NMO spectrum disorder. So always remember, when you're suspecting autoimmune cause for optic neuritis, include an NMO antibody also in their workup. And next entity that I would like to say is the infectious optic neuropathy, especially in country like India. There are various viral or bacterial infection which can present as optic neuritis. The most common being syphilis, TB, or even HIV. So look for history of any preceding fever, exposure to infective organism, or any travel to endemic countries. Or endemic areas, and other clinical features like associated meningitis, encephalitis, meningoencephalitis, or ocular, intraocular inflammation like vitritis, retinitis, then these patients require extensive laboratory investigation, including a CSF analysis to confirm the diagnosis. So the approach for optic neuritis in this era of biomarkers, I've taken it from an article by Professor Johnson. Like, he says, MRI brain on orbit is mandatory for all patients presenting with optic neuritis, and always test for aquaporin and MOG in patients with atypical neuritis, and consider aquaporin for any optic neuritis unless it's a classic MS on MRI and a mild vision loss. And do infectious and inflammatory diagnostic workup for patients with atypical features and associated systemic abnormalities. So let me finish with an interesting case. A 23-year-old male came with the right eye followed by left eye diminution of vision within a span of 3 days. It was painless in the past 1 month. There was no other history of any numbness, weakness, fever, and he's a teetotaler. There was no chronic medications. Family history was unremarkable. Systemically, he was fine. He had received IV steroids for 3 days followed by oral steroids, and he was on oral steroid 40 milligram when he had presented to us. And the vision on presentation was 3/60 and 24 in both the eyes. Pupils were sluggish. Color vision was impaired in both the eyes. Slit lamp and adnexa was normal. And this is a dispatcher which showed mild pallor in both the eyes. And the fields in the right eye was central and some few scattered defects, non-specific pattern. The left eye was constricted. And this is the MRI image of the patient. Patient had an intraorbital, orbital apex, and the chiasmal nerve thickening and signal in the nerve. So which we suspected optic neuritis, bilateral involvement. So he underwent all the blood workup. ESR was negative, NMO, MOG was negative. All the autoimmune, the granulomatous were all negative. CSF analysis showed some pleocytosis, but the glucose proteins, MTB, were all negative. So the provisional diagnosis was atypical neuritis, long segment involvement, bilateral with a bilateral vision loss and a poor recovery post-steroids. It was a seronegative. I suspected a seronegative NMO spectrum disorder. But the clinical profile, young patient, adolescent male with a sequential vision loss, prompted to think of LHON. So we advised him to complete the genetic testing also. Unfortunately, he was positive for LHON. For 11778 was positive. So it was a case of bilateral optic neuropathy secondary to LHON. So I would like to say that the literature evidence shows that features of optic neuritis in Western studies cannot apply to patients with Asian population, and we ophthalmologists should be aware of various presentations of the condition to provide an accurate diagnosis and appropriate management. So optic neuritis in our population needs detailed investigations routinely. Thank you.